So hello, my name is Joyce Tung. I'm from 23andMe. I'm a geneticist by training, but I've been at the company for 12 years, so forever. But as you might expect, this topic of direct-to-consumer genetics is near and dear to my heart. And I will be here today and tomorrow if anybody just wants to come and talk about it, because I love to talk about it. Okay. So I was asked to talk a little bit about sort of, who our 23andMe customers are, just to help set the stage for kind of talking about consumer genetics and diversity. So just wanted to let you know, we have a mission, and our mission is to help people access, understand, and benefit from the human genome. And I think today we're really talking about the different populations that use consumer genetics. It's really about the access. And helping people get access to their genetic information. So as has already been kind of discussed, 23andMe has the first and only DTC genetic service with reports authorized by the FDA. There's a bunch of different kinds of reports focusing on various health dispositions, carrier status, but also traits, sort of some wellness phenotypes, and also ancestry. So in terms of making genetics accessible, this is one of the things that attracted me to the company to begin with, because I felt like genetics was something that I wanted to see getting out into the public more. So there are a couple of different ways in which we've tried to make genetics more accessible to people. One of the primary ways is to make the test sort of more of a consumer price, right? So just as a sort of personal anecdote, I got some 2 variants tested through my doctor like 10, 11 years ago. And each test, which was for 1 variant each, cost me $400 through the clinic. And so, you compare that to the cost of genetic testing today, where you're looking at many, many variants, for $100, $200, $300, making something affordable to people is part of making something more accessible. Another important aspect is to make the reports easy to understand. So we've gone through a lot of rounds of internal testing and design in order to really highlight what are the key points that people need to take away from these reports, and how do we make them front and center. And we've showed that for these key points, we're getting greater than or equal to 90% comprehension across a wide demographic. So 23andMe is also what we might term over-the-counter, in the sense that it does not require a physician's prescription in order to access it. Again, for some people who may have more trouble getting access to a physician who will, help them get this test, or perhaps, they just don't have the time or the inclination, this is just removing one potential barrier to getting access to their DNA. In addition, 23andMe is available online. And so I think, one of the things that we think about is that there's a lot of people who may not live near a clinical center where they offer genetic testing, or maybe similarly, they don't live somewhere near some place where they can get a physician to give them genetic testing. So this is something that allows people who don't necessarily have great access to those resources, again, to get genetic testing if they want to. In addition, for people for whom privacy is a concern, it's an opportunity for them to get their results, and if they prefer, not to share it with anyone. So, there are going to be some very privacy-minded people for whom this is a concern, and this is just another option for them. So just to get into a little bit of data about who are 23andMe's customers today. So as has been mentioned before, there's millions of people have undergone direct-to-consumer genetic testing. We've sold about 10 million kits. And in terms of their ethnicity, we are primarily European, but fairly substantial chunks of Latinos, African Americans, and East and South Asians, although less than you would expect based on US demographics. The age distribution is pretty bimodal. It's pretty much always been like this. You see one peak sort of in the 30s and another one in the 50s to 60s range. And it's slightly more female than male. In terms of education, You'll see that our customers on average are a little bit more well-educated than the US population. There are substantial numbers in groups both with or without a bachelor's degree, but on average, they're a little bit more well-educated. I think unsurprisingly then, they're also a little bit more well-off than the average American on average. So again, substantial numbers in both sort of the lower and higher income brackets, but on average, a little bit more well-off. In terms of the location, it's a little bit hard to see. These states are basically colored by the number of customers in that state, not relative to the population density of that state. But since we are based in California, it is perhaps not surprising that most of the state with the most customers is California. Otherwise, you tend to see it a little bit more on the coasts and in the bigger states. Okay. And so I also wanted to talk a little bit about how these customers participate in research, which is obviously a topic that's very interesting to me. So about 80% of people consent to research. And I always thought this was kind of interesting because in the early days, there was a lot of discussion within the company about we really have to show how, participating in research will benefit people individually. But I think as you heard from the women who spoke earlier today, and I think we've heard time and time again from our customers, they're participating because they think they can help other people and they want to help other people. And I think that's been very, very consistent, which is, I think, both wonderful for research and also just gives me a lot of faith in the human race. Now, in terms of research participation by ethnicity, so these groups are by computed genetic ancestry, not self-reported ethnicity. But the two sections, one is consented, so did they agree to the main research consent? And then after that, we gather most of our phenotypic data, right? Diagnoses, habits, that sort of thing, through surveys. So this is just looking at who took the first survey. And so you'll see that they're pretty similar across the board. There isn't huge differences, that there's a slightly less participation amongst, I think it's East Asians, South Asians, than the other groups. And then this is largely consistent across both the consent and the survey taking. In terms of the age, you're not seeing huge differences here, like in terms of who's consenting and who's taking surveys. We're looking at pretty similar participation rates across all the age groups. And participation by sex, so both men and women are consenting at a very similar rate, but we see pretty consistently that women participate at a small but increased rate relative to the men. So yay us. Okay, so we also want to talk a little bit about how the lack of diversity in research, genetics research, impacts the service. So we're not going to sort of make the point again that there isn't enough diversity in research. I think we all know that. So how does it impact the sort of downstream applications? So, fundamentally, we can't provide information that we don't have. So here I've tried to bucket the different reports that we have by the ancestries that they are applicable to. And I would like to make the point, too, that we actually make an effort to try to find reports that represent non-European populations as well. So this is kind of how we're doing while making that effort. The reality is just that there's, if we're talking about the number of topics we can cover, more topics have been studied in European populations, and that is the data that we have to share. So those were generally more of the sort of low frequency, high penetrance variants, but the lack of diversity also impacts polygenic risk scores that use common variants. So here, there may not be as much of an issue that there aren't, these common variants aren't found in all the different populations, but in terms of the population size that you have to do the research and build the model in, the larger the sample that you have, the better the model that you can build. And so because of the smaller sample sizes that we have for non-European populations, the models that we build just can't quite be as good. So here I'm looking at the performance of a type 2 diabetes model that we trained across ethnicities. And we did our best with the data that we have, but you can see that we're still getting much better performance in Europeans than we are in, for example, well, any of the other groups. So I just wanted to close out on some of the efforts that we have ongoing in order to help improve the diversity in our research, which I think is not only good science, but also the right thing to do. So for example, we have a couple of projects, one called the Global Genetics Project and one called Populations Collaborations, in which we are trying to develop reference populations in groups that are currently underrepresented amongst our customers. So in the first, we're actually reaching out to customers with 4 grandparents from particular countries that are underrepresented. And in the populations collaborations, we work with academic researchers who are doing research in populations generally outside of the United States that we don't have good access to. And so working with them and local researchers in order to develop those reference data sets. In addition, we've made investments into doing whole genome sequencing of some of our African American customers as well as some of our Latino customers, because that helps us improve the imputation panels that we use for research. So the more data that you have, the more discoveries that you can make. But currently, most of the publicly available sequence data that we can use for imputation is in Europeans. And finally, we're also looking at different methods that we can use to develop these polygenic risk scores that can better leverage the data we have both within and across populations to develop better scores for non-Europeans. And we presented a poster at ASHG that showed some gains of using these kind of more meta-analytic methods. And so we're hopeful that we can make some strides, even as we're trying to increase the number of non-European individuals who are participating in research. So I will close with that. Thank you.